Thank you for having me. So I want to talk today about improving traumatic brain injury care. I'm honestly going to bring up more questions than I am answers today. But it's something that's very important in the pediatric population for a number of reasons. I have nothing to disclose. So why are head injuries important in kids? Because head injuries in kids are the rule rather than the exception. Obviously, older kids have normal-sized heads, just like the rest of us, but small kids are like Stewie from Family Guy, have huge heads and often get injured. So every polytrauma that we see has a head injury until proven otherwise. And I think that's where they differ from children. And that's why it's such a challenge for us to care for them. The American Academy of Neurosurgeons has talked about how the rapid physiologic resuscitation of these kids is really imperative and really key. And all of the guidelines that we have so far are focused on that. One of my colleagues, Ashley Yao, who's a neurosurgeon, loves this. He calls it the Goldilocks Principle. Everything pretty much just has to be just right. And as all of you know, working with kids, that can be very difficult. And these principles hold true for adults as well, but children are just more sensitive to hypoxia, more sensitive to hypercarbia and hypocapnia, are more difficult to resuscitate from a fluid standpoint as well. That said, we are improving. And I think that's important to think about. Why we're improving, we'll talk about in the next couple of slides. But though we're seeing more hospitalizations for children and young adults, we're seeing the odds of in-hospital mortality go down for each additional year. And this is Canadian data. So how are we improving? Many different ways. One of the ways that we've improved here and in the US as well is through the regionalization of our trauma care, through advances in pre-hospital care. It's one of the biggest areas that we've improved over the last few years, particularly with the advent and the training of advanced care paramedic teams. So the ACTS team, the Orange team out in Toronto where I used to work, as well as our ITT team here, and expanding their scope of practice as well. Our diagnostic imaging practices have changed. We're more judiciously using radiation in our pediatric population. We're no longer doing CTs on every child who comes in, and our protocols are just faster, even with this less radiation that we're delivering. We are getting kids faster to neurosurgeons and are able to better evacuate hematomas, and we've made a number of advances in neurocritical care. Why is it difficult to develop guidelines in kids? Because it is. Currently there are guidelines out from the neurosurgical associations, but none of them are really evidence-based, and that's where we find there are a lot of challenges. And one of the reasons for that is that there's an incredible amount of practice variation from one center to another in the US, in Canada, and even locally if we look at BC, and this is another area where moving forward we should be able to improve. It's very hard to recruit children into these studies, and so what we end up is with a paucity of that true level 1 RCT-based recommendations, which allows people to go and do their own thing at their centers. People are developing more and more comparative effectiveness studies, which may help in the future. But just to give you an example, these are all the RCTs in traumatic brain injury in kids. The only one that's really panned out is hypertonic saline. Everything else was no different or problematic at baseline, which makes it really difficult to move forward and decide what we're going to do in the pre-hospital setting when even within our tertiary care hospitals it's very difficult to agree and come up with a consensus. So in the pre-hospital, some pre-hospital and transport considerations. Transferring children to a pediatric trauma center is being shown to improve care. Pediatric TBI protocols for the community as well, especially when based on physiologic parameters and monitoring that's appropriate for children. And that's one area that we can all standardize across the province. Avoidance of hypoxia, a single hypoxic event, it leads to a worse outcome in the pediatric population. And Australia has really led this field of pre-hospital intubations for the pediatric population with their advanced care paramedics and have excellent outcomes. There are many courses out there that I'm sure a lot of you know of. There are more and more in Toronto as well, pre-hospital care providers who are participating in courses like the AIM course. And really moving away from that scoop and run approach for airway management, the pediatric group, with excellent outcomes. So how can we improve the acute care management? And like we talked about, Goldilocks Principle here, and judicious use of fluids is another area as well, and time considerations. So expedient imaging is something we struggle with at our center at times, especially after hours, as well as having a short interval between CT and surgical intervention, which in a place like BC, especially with such a large province, and us being quite far up north in parts, can be really challenging. And this is an area where a lot of people are trying to explore telemedicine and other options for improving that time to the OR. What are we trying to do locally? This is an initiative that we currently have going on at BC Children's, where we're working on our pit stop assessments of pediatric trauma patients with evacuatable hematomas, along with BCEHS and our ITT teams, to never take them off the stretcher, bring them straight up to the OR, and do this truncated 90-second assessment in our AD. And hopefully that will get some of our kids faster up to the OR. There are many resuscitation updates, but what I want to emphasize here is that simplifying order sets, picking one medication that you use well, both for pre-hospital care providers, but for us too at BC Children's and at tertiary care centers, has been shown to improve patient safety, and at the end of the day, it can really improve care. Why does this matter? It's been shown time and time again, everywhere from the on-scene rapid resuscitation up to the pediatric neurocritical care unit, that adherence to guidelines, even though they're based not on level 1 evidence, improves care. If we standardize our practice, we can show a more favorable disposition from hospital. So just because we don't have the data to support exact, precise, different interventions, if we standardize our care, not only will we be able to research what we're doing further and see what works and what doesn't, but it actually has been shown to improve care. So in summary, physiology is key, like we talked about. And what I'm really hoping that we move to as a province and as a country moving forward is going from empiricism to real evidence. And I think the only way we can do that is by all doing similar things and adhering to guidelines. So 2 other little points I wanted to make today. One of them is about severe TBI outcomes. And the reason I bring this up is that I want everyone to realize that it's not futile. Often there's a sense for us anyways when kids come in with a blown pupil, GCS of 3, that all hope is lost. And the fact is in kids that's not always the case, which is a great thing. It's been shown that even kids with a GCS of 3 or 4 can have an excellent neurologically intact survival at 10 years, up to 15% of them, and it's hard to predict who they are. That first on-scene GCS that's determined by the EMS providers is actually predictive of outcome and is a useful piece of information. Fixed dilated pupils, especially in children under 13, not suggestive of futility. Many of these children, especially if they have an acute extradural hematoma, are survivable and go on to live very productive and well lives. So overall, there are lower mortality rates in the children and better functional outcomes. Do you want to speak a little bit about spinal motion restriction today? These are some updates that one of my colleagues, Garth Meckler, who I believe spoke to yesterday, has worked hard on with the BCEHS community. And one of the things we're looking for in children, just like adults, is moving away from rigid splinting of the spine for the reasons that you guys are all quite aware of. Some pediatric specifics here, though, is that children do have anatomic differences than adults, but are, for the most part, relatively easy to assess in the older kids, and therefore should be treated in a lot of ways the same way that we do treat these adults. What kids do sometimes have in special consideration are these predisposing medical conditions like trisomy 21, ankylosing spondylitis, which adults can get too, and a lot of other genetic disorders that can predispose them to more C-spine injuries or ligamentous injuries of the spine. And that's something that's being built into the current SMR guidelines for BCEHS. The biggest thing that we see, and I think we struggle with as well, are these small children that are screaming at the top of their lungs that come into the emergency room, who fell 4 stories out of a window, and you're like, did they dive straight into the ground? Should I forcibly restrain them? And it's a difficult question, but time and time again, people have looked into this. Children who are under 4 or 5 years old will clear themselves. If you have a screaming child who's moving their neck back and forth, they're very, very unlikely to have a significant C-spine injury. And I think it's taken all of us, myself included, some time to get there where we're not going, oh God, you fell 5 stories, I'm gonna restrain you, I'm gonna pin you down. It's really not necessary, and it can be exceedingly traumatizing for the child and can cause injury. We currently have a trauma manager at BC Children's who comes from Vancouver General, who's adult trained, and her first pediatric trauma she saw was a 3-year-old who fell out of a window. She walks into the trauma bay, she wanted to see it, and I was running it, and I was singing Wheels on the Bus, and the pharmacist was blowing bubbles. The child had fallen 3 or 4 stories out of a window and was sitting up in mom's arms, and she's like, wow, what have I gotten myself into? But I think she's good now. She's happy she's joined us. She's not PGH anymore. But all that to say, you know, taking that kid and trying to pin him down when he was practically climbing onto the CT scanner was probably not the right thing to do. And I think we're all moving towards that. We've got the evidence to support that. Thank you.